I welcome Dr. Rishi Deshpande. He is my senior from University of Toronto. If I would be taking that introduction first. He's the director nephrology and renal transplant science, Jaslok Hospital and Research Center, and also the director of critical care nephrology at Sir H.N. Reliance Foundation Hospital, Mumbai. So I would request Dr. Rishi to start with the first talk. That is the practical considerations in managing onconephrology cases in the ICU. And if you can share, sir, your presentation. Yeah.
Are we good here?
Yes. Your screen is visible, sir.
Lovely. Okay, so first let me start by thanking Dr. Tapas for this kind invite. And just meeting people from the same alma mater always makes you very happy. Yes. So
Thank.
this was an interesting talk when I was asked to give it. So onconephro was one of my first passions. In 2010, it just happened that Tata Memorial Hospital in Mumbai was not having any nephrologist, and the then director requested me to join as a visiting faculty. So that's how my journey in onconephrology actually started. For the next 12 years, I practiced at Tata Memorial as a visiting nephrologist, basically doing twice a week free OPDs and trying to learn onco. That day when I started, onconephrology was not even that name wasn't there. So it was just a nephrologist working in an oncology setup. But then over a period of time, onconephrology as a subspecialty has evolved. And today what we are talking is three specialties merged into one: oncology, nephrology, and intensive care. So let us see how best I am able to come up, put across the considerations in managing these patients in the ICU. Okay. So why is it relevant to know about onconephrology? A lot of our patients with malignancy are surviving much longer, long enough to develop renal complications. You know that patients with kidney injury or nephrotoxicity, it limits the therapies available for curing their malignancies. A worsening acute kidney injury is directly responsible for mortality, and we know that an ICU AKI in a patient with oncology illness results in almost 50 to 70% mortality. Also, it prolongs the hospital stay, the hospital bills, higher infections, and then multi-system failure is not uncommon. So when you look at patients with onconephrology in the ICU, you're looking at three things. One, you're looking at cancer-related injury. Second, you are looking at treatment-related toxicities. And third, you look at ICU or critical care illness-related AKIs. So there's from your sepsis, your hypotension, multi-organ failure, etc. So, if you broadly classify the types of kidney injuries in an ICU setting in oncology, you look at acute kidney injury. So, that is classified classically as renal, pre-renal, intrarenal, post-renal. And the commonest ones, intrarenal, are AINs and ATNs. TMAs also form a significant cohort. Not to forget the easy ones, the pre-renal and the post-renal, because they are easily manageable. So, it's important to pick them up early. CKD progression. Patients with pre-existing renal injury or CKDs are the most vulnerable, and they can get repeated insults with chemotherapy and multiple episodes of AKI, resulting in worsening of their underlying CKD. Electrolyte disorders are very common. Tubular injuries from both malignancy and the malignancy treatment are not uncommon at all. Sometimes they can be life-threatening and rapid in onset, and you need to pick them up early and treat them properly. Sometimes you could have glomerular diseases like paraneoplastic manifestations of the illness, right from minimal change to membranous, everything can be seen. And like I said, post-renal or tumor-related obstruction should never be overlooked. So when you look at this patients, you know, we have to understand that ICU specific challenges are important. So sepsis plus malignancy, hemodynamic instability, very important to look at the drug-drug interactions. To this audience, I did not say, but you know that EGFR the calculated eGFR based on the last 24 hours creatinine does not hold. And what you actually need is a timed urinary creatinine clearance to accurately decide the dosages of the chemotherapeutic agents, the antibiotics, and the antifungals. Immunosuppression leads to risk of infections and delayed recovery. Fluid balance, and we always say this, that fluids are basically drugs, and use them with the same caution and the relevance that you would when you were to use a medicine in the ICU. So both overload and under resuscitations can lead to kidney injuries and lung injuries respectively. Okay. So what is the never forget the basics? When the patient is in the ICU, look at the baseline renal function, look at the diagnosis of the malignancy, stage, treatment line, identify the recent medicines that have been added or subtracted from the regimen. Look for common things, volume status, obstruction, like I said, pre-renal, intrarenal, post-renal. Keep that algorithm in your mind when working and decide rapidly whether the syndrome is toxic, immune-mediated, obstructive, or hemodynamic. Practically, triage there should be in your mind once the ABCs have been done, the labs have been sent, a quick ultrasound of the kidney and bladder is done, all the nephrotoxic agents are taken off the table, volume status has been established. Then you decide any specific treatment based on the etiology. So, simple investigations. Urine microscopy should never be forgotten or underlooked. It is very important to look because if you have an active urinary sediment, CAS, WBC cast, or hematuria, then you know that you're dealing with a glomerular injury, right? Quantification of proteinuria is significant. Either it's a light chain nephropathy or it's a glomerular illness, paraneoplastic, or whatever the reason is, and those are important. A thrombotic microangiopathy or rhabdomyolysis are two important complications to suspect because unless you suspect them, you are not going to look for them. Renal ultrasound should be a basic scanning done. Make sure that there is no obstruction from the disease or from the treatment. Contrast procedures in patients with pre-existing CKD or AKI should be used only if it's going to lead to a change in management immediately. Kidney biopsy is a wonderful tool. You should use it when you are not sure of your diagnosis. Because if you feel that it's going to change your treatment, then obviously you should do it. When to biopsy a patient? If you have an obvious diagnosis, what will you gain by doing a biopsy? Uncertain diagnosis, right, is important. Atypical presentations like a nephrotic range proteinuria, very important. But if you have nephrotic range proteinuria after seeing a VEGF inhibitor, you don't need a biopsy straight away, right? So atypical presentations are important to pick up. Active urinary sediment suggesting a glomerular disease with rapidly worsening renal failure, you are unsure of the cause. You don't know whether it's related to the disease or it's an independent kidney problem happening there. Incomplete response to empiric therapy. You suspected an ICI, AKI, you gave steroids. 72 hours, 96 hours, no improvement. Yes, you should consider a biopsy. Need to distinguish the ICI, AKI from an ATN infection or a TMA. You should consider. So what I'm going to do today is I'm going to walk you through three simple cases in the ICU and try to bring home some points that I feel are relevant in today's day and time. We are in an evolving age from genomics, proteomics, precision oncology meeting precision nephrology, helping the intensivist achieve the goals of care with onconephrology patients is what we are trying to look at today. We are trying to look at the newer biomarkers as to when they are actually going to be available and change our standard of care today in the ICU. We are looking at AI related diagnostic algorithms which could supplant or take over the way we diagnose the onconephrology cases today in our ICUs. So we have to be moving with the evolving times and stay in line with global development so that we remain on top of our branches. So this was a young 48-year-old male with a bulky large B-cell lymphoma. Within 18 hours of presentation, patient was oliguric, hyperkalemia 6.4, phosphate of 7.8, a uric acid of 14, and a worsening creatinine. Patient was in the ICU, telemetry. Raspberry Pi is very easily available now. No reason not to use it. Not expensive at all any longer. Use Raspberry Keys. Aggressive fluid management, alkaline diuresis needs to be established. Hyperkalemia needs to be treated on an emergency treatment. Dialysis is only for refractory patients, refractory hyperkalemia, refractory acidosis, yes. Otherwise, raspberry case and aggressive fluid management should help in most of the cases. So in these patients, what needs to be done? You confirm the TLS pattern, relative time to chemotherapy, yes. Once you review, you feel, yes, it is possible that debulking the tumor led to this problem. Monitor the labs frequently, you make sure that your potassium is managed well, and so the phosphorus, dialyze early if the hyperkalemia is refractory. Most important oncologic nephrologic emergency, because this is like time tested model of onconephrology emergency with excellent outcomes. So typical labs: hyperkalemia, hyperphosphatemia, hyperuricemia, and hypocalcemia. Risk increased by bulky disease. Other correlates would be high WBC, high LDH, and chemosensitive tumors. It can either be spontaneous or secondary to treatment. So management, again, like I said, aggressive hydration, establish alkaline diuresis, use raspberry case, repeat the dose after 12 hours if the uric acid is still high, prevents urate crystallization in the renal tubules, and a prolonged ATN can be prevented. Then allopurinol to reduce the production of the uric acid, treat hyperkalemia, avoid routine calcium replacement unless your patient is symptomatic, dialysis in specific cases. So a TLS is like a time-tested situation in oncology emergency care. Important now is that when in 2010 when I started with Tata Memorial, Raspberry case was expensive and we hardly used to use it. Today it is standard of care. It is no longer expensive. So many available options now. The cost is not even like 10,000. So there's no reason not to use Raspberry case in hyperuricemia and a TLS. Outcomes is really very good, and I'm sure that you are already using it. The second case is a patient on pembrolizumab, and the creatinine goes up in the 67-year-old lady from 1 to 3.1. The evaluation shows mild pyuria, no obstruction, no shock. Patient is also on a PPI. What do? We suggest to hold the ICI, exclude the infection, hold the biopsy for now, start steroids, and see how it goes. So you do the regular imaging, ultrasound, urine, whatever we just discussed before. Biopsy, like I said, only if there is uncertainty or there is a suspicion of another disease. And resumption of ICICI is a tricky topic. We should do it after a lot of discussion between the nephrologist, oncologist, and the intensivist as to what is the risk of recurrence, because we should counsel them about the recurrence risk on rechallenge. Immunotherapy in oncology. Core concepts need to be developed as the number of medicines evolving in oncology care. I think they are right now, the number of drugs are maximum in medical oncology, the newer ones. And when you look at immunotherapy, there is, the tongue twisters are evolving at a very rapid speed, right? So the most relevant to nephrology, the immune checkpoint or the ICICIs are CTLA-4 inhibitors, the ipilimumab, the PD-1 inhibitors, Nivo and pembrolizumab, the PD-L1 inhibitors, the atezolizumab and the durvalumab. Durva is now much more being used. So what do these ICI do? They basically inhibitory immune checkpoints. So that leads to enhancing the T cell activation, which leads to a better anti-tumor response, but it also leads to immune-related adverse events. And this is where the kidney comes in the picture. Other immune therapies, the CAR T cell therapy, we'll talk about that a bit. Bispecific antibodies, again, we are seeing more usage of these class of drugs. Cancer vaccines and cytokine therapies. So immunotherapy related renal injury. Overall, when you listen to a senior oncologist, Andrew Beeris, delivering a talk on on ICIC immune therapy related side effects, you see that their focus is primarily on endocrinopathies and hepatic injury. Renal injury, in that pie diagram is only 2 to 5%. Even though we as nephrologists will see only those problems more, but in the real bigger picture, it's only 2 to 5%. And what are the common things? Is that there is a combination of IC immune checkpoint inhibitors, or there's a concomitant nephritogenic or nephrotoxic drugs, or the patient is a pre-existing CKD or a post-kidney transplant or something like that. Why does it happen? Like we said, the T cell activation leads to the response where there is cytokine mediated injury. So immune mediated hypersensitivity kidney injury is what is happening. And how would it present? In 80 to 90%, it would present as an acute interstitial nephritis. In some cases, it could present as a secondary glomerular nephritis with minimal change or membranous nephropathy or even an IgA or C3 nephropathy. In few cases, a thrombotic microangiopathy could be the presenting symptom. How would you pick it up? There's a rising creatinine, which usually sets in after weeks or months of therapy. There is a sterile pyuria, so the WBC is leakage in the urine from the glomerular injury, mild proteinuria. Eosinophilia needs to be looked for. If present, it's a very good diagnostic marker, often associated with extrarenal immune-related adverse events like rash, skin rashes, colitis, and like I said, thyroiditis. Very common in this group of patients. Colitis and thyroiditis, and even hepatitis. When there are associated extrarenal adverse events with the immune checkpoint inhibitors, the diagnosis is very obvious. Otherwise, it can be tricky. You need to evaluate, rule out our, again, never forget the algorithm in a kidney injury, pre-renal, post-renal, intrarenal. Look at the reversible causes first. It is critical because ICI, AKI is overdiagnosed, and then you do the regular workup, urine test, autoimmune panels if you are suspecting something else. Obstruction needs to be ruled out in every case. Kidney biopsy, even though it is a gold standard, when should you use it? If the grade is more than 2 for the AKI with atypical features and no response to steroid. Biomarkers, like I said, I'll talk about them in brief, but they're still quite experimental. The interleukin 9, TNF alpha, single cell RNA sequencing, or circulating T cell profiling, though they appear like the future because it's like a liquid biopsy, non-invasive immune profiling instead of biopsy looks very attractive in diagnosing. So grade of ICI associated AKI, the 1, 2, and 3 to 4. So basically, depending on how high the creatinine has gone up from the baseline, and the management would include steroids. The dose would be higher in higher grades of AKI, and the re-challenge would be permitted in lower grades but not in higher grades. So steroid strategy, if it works, then you taper it over 4 to 12 weeks. If steroid is not able to reverse the illness, then you can consider other immunotherapies. Rechallenge, like I said, recurrence risk is pretty high, almost 1/3 of cases. And you should be really worried to use it if the AKI was very severe or the biopsy showed you a very severe glomerulonephritis. Kidney transplant is a very sensitive area, patients, because with the immune checkpoint inhibitors, the risk of infection, acute rejection is very high. Strategy would be to reduce the dose. It's like choosing the smaller problem, choosing the lesser evil, like I say always. If you feel that you are life-saving therapy, then you can give up on the kidney and save the patient from the cancer. But otherwise, if the if there are options available, then you should obviously answer. The immune checkpoint inhibitors, most of them are not cleared by the kidney, so no dose adjustments. We discussed this, that most of it is an AIN. ICI management, you should stop the drug first, make sure the other causes are ruled out, then try with steroids. If they respond, great. If not, consider a biopsy. The third case, like I said, so this is a 59-year-old male with a relapsed lymphoma. Day 2 after a CAR T cell therapy, referred for fever, hypotension, rising lactates, oliguria, and increasing creatinine. So, how are you going to manage this patient? Fluids, vasopressors, steroids, and RRT. You can consider a tocilizumab in such cases. So, what is your diagnosis? So after CAR T cell therapy, AKI is not uncommon, especially because of the CRS. So CRS refers to the cytokine release syndrome. which is part of the mechanism of action when you are giving this therapy. So the things that would happen in a cytokine release syndrome would be the classic ones: hypotension, capillary leak, inflammatory injury, and a TLS. You need to monitor the urine output, hemodynamics very aggressively, and by agents like steroids and tocilizumab can improve the kidney outcomes by controlling the CRS. Okay, so this is showing you the different I don't know if I should use the word old, but time tested oncology drugs, and their side effects on the kidney goes all the way from cisplatin to interleukin 2. The common ones, like when I was studying pharmacology, gemcitabine and mitomycin were the two drugs that used to be responsible for TMAs. Now there's a whole list of them. So different injuries, the commonest one that you are going to see in the ICU is tubular injury. Following that is going to be an AIN. Then is an ATN. And last would be a TMA. That's the way you're going to see it. Secondary GN is very less common. Then these are the newer drugs, like we said, the whole list from PD1, PDL1 inhibitors to CTLA4, VEGF inhibitors, TKIs. So TKIs, 2012, 2013, sunitinib, sorafenib evolved, and we started seeing a lot of non-specific changes in the urine, mild subnephrotic proteinurias, electrolyte imbalances, and we published a paper at that point with the kidney biopsies that we had done in patients on sunitinib, showing the tubular injury consistently in that group of patients. CAR T cell therapy, bispecific antibodies, these are all newer drugs, therapies that are evolving. PARP inhibitors, olaparib, it presents like a pseudo AKI. It inhibits the tubular creatinine secretion. Remember the old drugs like probenecid? So it's something like that. The PARP inhibitors would increase the creatinine, but without actually damaging the kidney. And the newer the mTOR inhibitors, we have significant experience with them in our transplant patients, but proteinuria is a drug limiting factor. Hemodynamic AKIs, electrolyte emergencies, both hyponatremia, I think is the commonest single thing that you will be speaking to your nephrologist for. Hypercalcemia and hyperkalemia are the other two. Hypercalcemia, how to treat is very simple. So hydration, calcitonin, bisphosphonates, and in resistant cases, you can think of denosumabs, which again is standard of care in a lot of patients. Myeloma kidney, the only thing to discuss here would be the high cutoff dialyzer. The rest would be standard care, right? So continuous RRT for hemodynamic instability, high cutoff, like I mentioned, and biopsy only if it's going to change your therapy. Otherwise, it's not really. The different modalities that we would use: CRRTs, hemoperfusion, plasma exchange, hybrid dialysis, and a mix of everything. Depends on the indication what we are using it for. Like somebody with a CAR T and a CRS, you would want to prefer heme adsorption because you have to remove the inflammatory cytokines. Plasma exchange or plasmapheresis. Now again, the membrane filtration is a much better therapy way of doing it than a centrifuge. And you see the improvement that you would get in a patient with hyperviscosity or myeloma or even a TMA with this. So hemoperfusion or extracorporeal therapy is in nephrology is an evolving topic, and it's a great area of great interest to me. So when we started the critical care nephrology program in Reliance Foundation Hospital now almost 6 years back, so we have a training program where 2 fellows are enlisted every year. So they are either are from nephrology or from critical care background who train with us for 1 year duration for critical care nephrology. And the maximum interest area actually right now is the extracorporeal therapies. A lot of evolution in the ICU with the POCUS and the hybrid extracorporeal therapies, the ECOS and the CPFA. Latest advances, so biomarkers replacing biopsy, precision immunotherapy, microbiome. This is again an evolving area in ICI toxicity, combination therapy, the stratification models, and genomic driven nephrotoxicity prediction. Biomarkers, it's an area in evolution. So I just want you to think about it like that, that is a liquid biopsy of the kidney, and the field is shifting from histology to multiomics. where you basically have a profile of each patient, and someday before we retire, hopefully, we see this becoming a reality in day-to-day practice. And they would include cytokine markers, tubular markers, complement markers, multi-marker panels together, and that would be integrated with AI models to improve our diagnostic accuracy and classification of the phenotypes. So this would be the future, I feel so. Precision immunotherapy, tumor and host profiling. So that is for the oncologist to kind of, as their evolution goes. But as far as nephrology goes, we have to look at the patients who, that 5% where they are going to need our help in managing the renal involvement clinically. Microbiome, I'm just rushing, as you know, I think I'm shooting overtime and I don't want to be very late. So microbiome is important. It's the second immune organ, the gut microbiome. And what has been shown is that dysbiosis is an important area for increased immune activation and organ toxicity, and specifically associated with colitis and nephritis. So, including fecal microbiota transplantation and probiotics have been kind of studied in this model in ICR related AKI. Dynamic real-time immune monitoring with different proteomics and AI tools. So the reason for showing you this is that it is evolving and we are actually at the forefront of it. So HN Reliance and Jaslok are both centers of excellence for onconephrology in the city, along with Tata Memorial Hospital, where I served for almost 13 years, like I said. And the trends in India is increasing use of the ICI. More transplant patients are also receiving immunotherapy as they are living long and developing cancers. And there's a lot of collaboration happening between oncology and nephrology services in almost all major tertiary hospitals. Challenges: late recognition, limited access to biopsy, cost of biologicals, but those are all something that can be managed. So high cutoff dialyzers, they're prohibitively expensive, but and also they are like, the result is very time limited, and you have to keep on using it again and again till the oncology drugs actually reduce the production. Adsorptive membranes, like we mentioned, the Oxiris and everything that we are using. Cytokine with cytosol with the CAR T CRS is a major application in oncology patients now. Um, So chemo-induced AKI, sepsis-induced AKI, early detection is very important. CRRT, when required, should be initiated early. So this, TIM2 and IGF BP7, it's a commercially available tool now in US at least, where you can actually, this called as NephroCheck. That's the commercial name for the test available to look at tubular injury early. India's status onconephrology is growing but unevenly distributed. And Indian Society of Onconephrology is established, and it's a major step for visibility and training. Formal onconephrology training is now available for people who seek to get advancement in this particular specialty, and the research is being widely published. So, best outcomes will come from shared decision making between oncology, nephrology, and critical care. Take away the turf wars. We are all here for the patient and the bettering the outcomes. Treat the kidney, but always first treat the patient with cancer. Important to understand any oncology treatment. If it is curative, you should keep that interest ahead of the interest of saving the kidney. Okay, there's nobody who would love the kidney more than me, but save the life of the patient. That's more important than worrying about the kidney. Collaboration is currency. Remember that it's the philosophy of care, and onconephrology is not just a subspecialty. It's something that embraces complexity, respects uncertainty, and ultimately strives to turn critical illness into an opportunity for precise, compassionate, and courageous medicine. Thank you for your kind attention.
Thank
Back to
you,
you, Dr.
Dr. Deshpande, for this, I would say, very pragmatic insights, and the future also, what you have shown is really encouraging. Now,
Thank you.
before we go to the second talk, I have a very practical, like I would say, challenge that happens in the limited resources, because you have also shown that in India, many things are actually in the infancy stage. So maybe we will be trying to get all those things. I just wish to know what is like your one most impactful modification in RRT strategy or something related to fluid management that you advocate that can significantly improve the outcome in the onconephrology patients? Maybe something that we face in our day-to-day practice.
Yeah, so few things. First is in onconephrology, a very important thing is not rushing to a diagnosis without completing your tick boxes. A lot of times I come across patients who have wrongly been labeled as an ICI, AKI, just jumping to diagnosis. And every, I used to always tell people that every pyuria is not a UTI. And, simple things like that need to be kept in mind. Sometimes we have seen people missing obvious things like obstructive uropathies related to tumors. You have a long, big lymph nodes down there obstructing the ureters, and you are worrying about AKIs when it's an easily treatable problem. So those things are very, very important. Another very important thing is to use CRRT early in TLS. If you have a oligoanuric TLS not responding to fluid and diuretics, please start CRRT early, because then the outcomes are far better. Because remember, TLS is a response to treatment. So these are the patients who are likely to do well if that 24-48 hours are managed well. So that's something important for all of us. The third is not to rush in with kidney biopsies in patients with oncologic AKIs, because hardly do they change the course of management. So unless you really are convinced that this is a atypical presentation or a non-responsive situation, only then you should go ahead with the biopsy. Otherwise, early biopsies, I see more harm than good in rushing with early biopsies in these patients who most of the times have an obvious diagnosis. Right? If you have an obvious TMA, what are you going to prove by doing a biopsy? It is a TMA. So you treat a TMA. Most of the times it's related to a drug or offending agent which you take off, and then depending on the situation, either replace plasma or do an exchange. So things like that are important. From a ICU perspective, if you look at it now, focus is very important in managing these patients, because a lot of these patients have cytokine storms or inflammation, and a lot of them have third spacing. And managing the intravascular volume is very important in predicting the recovery from AKI.
Yes.
Last but not the least, nephromegaly as a cause of AKI should be remembered, particularly in such volume overexpanded patients. Thanks.
Thank you. Thank you, Dr. Deshpande, for those clinical pearls. Definitely, this would help.